Hello everyone. I am Kaveh Khoshnood. I'm going to start with a brief introduction uh, before I pass it over to my colleague, Dr. Anees Chagpar, for her presentation. I am a faculty at the Yale School of Public Health, and I am the faculty director for Humanitarian Research Lab, with a particular interest to address the health of populations that are affected by humanitarian crisis, including armed conflict. And I've had a focus on the MENA region in the Middle East, North Africa region. My own training is in infectious disease epidemiology, but every time I speak with humanitarian organizations, the NCDs, non-communicable diseases, come up, and cancer care and treatment has come up multiple times when I have visited these humanitarian NGOs. And I recall there was kind of a disturbing story when I visited Lebanon, and I went to a humanitarian organization, and there was a Syrian oncologist who had been displaced into Lebanon, and he had started a mammography clinic for Syrian refugees. I think he was the only one doing that, and he had been screening women for breast cancer. And he told me that one of these women had early stage breast cancer, and he referred her to UN agencies that provide financial support for cancer treatment. And they told this woman that, you're very early stage breast cancer. We cannot fund you. Come back, whatever, a year later or so. If your breast cancer is advanced, then we can provide support for you. And that was such a disturbing story that I heard. It's completely sort of an anti-public health issue, because we're supposed to be able to screen and treat breast cancer patients as early as possible, not wait. But these UN agencies have very limited funds, and they make these decisions about people who are in late stage breast cancer and are likely to die. They kind of focus on them, the limited resources that they have. So I was very disturbed by that, and I was trying to figure out what I can do to support this project. And I ended up working with one of our students long ago named Jude Alawa, who comes from a Syrian family background. And he ended up doing the first study looking at cancer awareness and access to treatment for cancer patients in Lebanon, both in the Syrian refugee population and the Lebanese population. And that was a very sort of meaningful study that he did, and it triggered conversation about different stakeholders to continue this work. I then learned that our colleagues called SAM's Syrian American Medical Society have launched a clinic, an oncology clinic in 2018 in Northwest Syria, which, as you may know, it's a conflict zone. Northwest Syria is not under government control. And SAMS, Syrian American Medical Society, is one of the few organizations that is able to provide care and treatment. And they actually had set up a clinic to take care of cancer patients. So I reached out to them to see what support we can provide for them. And what they wanted was, they had been collecting a lot of data, but they hadn't really had the time and capacity to analyze this data. They wanted us to support them and put out reports. And I reached out to my colleague, Dr. Anees Chagpar, who's a wonderful surgeon, oncologist, and I asked whether she would be interested in participating in this project, and she said yes. She applied for a grant from the Macmillan Center and was able to launch this study that she's going to tell you about. Just briefly, I want to mention to you, Dr. Anees Chagpar is a full professor in Department of Surgery at the Yale School of Medicine. She has specific expertise in breast cancer. As you can see, she has multiple master's degrees in addition to her medical degree. She has a master's in public health. She has master's in bioethics and medical humanities. She has an MBA from Yale. So she really, and she's also a fantastic communicator. You may have come across her Coursera course on breast cancer, which is extremely popular. and she's quite active on social media, and she's very passionate about global health and leadership in academic training. And I'm really delighted that she agreed to lead this project. And today she's going to present to you what this, where this project has gone over the last 2 years. Dr. Chagpar, I'll pass it on to you. Thank you so much.
Thanks so much, Kaveh. So it's a real pleasure to be here to present this work. This, as Kaveh mentioned, was a collaborative effort between the School of Medicine, the School of Public Health, as well as our colleagues from around the world through the Syrian American Medical Society. And it was really a mixed methods investigation into the experiences and outcomes of patients with breast cancer in the SAMS clinic in Northwest Syria. So before we dive in, here are my disclosures. The ones at the top really will not be relevant to today's discussion. I'm not going to be discussing anything that is pertinent to those funding sources. But I do want to highlight, as Kaveh mentioned, that the work that I'll be presenting was funded in part by the Yale Macmillan Center Program on Refugees, Forced Displacement, and Humanitarian Response. And we are very grateful for that support. So if we take a step back and we think about the Syrian conflict, this has really been going on since 2011, and it started as a civilian uprising rooted in the Arab Spring. And we know that this really took on an armed conflict and involved targeted strikes, particularly on healthcare personnel and facilities. It caused over 400,000 deaths, and there were more than 5.6 million refugees out of the pre-war population of 22 million. That 5.6 million is likely an underestimate. And the World Health Organization in 2017 called the Syrian conflict the worst man-made disaster the world has ever seen since World War II. The chart which I show you below is really the change in level of life satisfaction in 163 countries, blue being better, life satisfaction, red being worse. And so you can see that over this period of time, life satisfaction in Syria has declined significantly. If we think about breast cancer in Syria in particular, these are data from GlobalCan. Breast cancer, as many of you know, remains the leading cause of cancer in women worldwide, and that is certainly the case in Syria. It's also the leading cause of mortality. And here you can see that this is not just among women, but breast cancer in Syria is the leading malignancy period across all genders and the leading cause of cancer-related mortality across all genders. So if we think about the map of Syria, I've highlighted here the capital, Damascus, in red, which you can see in the south. Aleppo is a large city in the north. And it was these two centers that really had a lot of the healthcare, especially prior to the conflict. Where SAMS came in was in establishing a clinic here in Idlib, in the northwestern part of Syria, where, as Kaveh mentioned, this was really a conflict area. And so the objectives of this study were to understand the patient experience and pathways to diagnosis of patients with breast cancer at the SAMS supported facilities in Northwest Syria, and to evaluate factors affecting stage at presentation and outcomes of these patients. So we did this with both a qualitative study as well as a quantitative one, and I want to walk you through both parts of the study. So for the qualitative study, we set inclusion criteria of patients who were diagnosed with breast cancer at the SAMS facilities who were living in Northwest Syria, who were at least 18 years of age or older. 90 patients were screened and 65 patients were excluded. The reasons for the exclusion were that 40 of them did not have a working telephone number or WhatsApp. 25 had either died or declined due to current illness or lack of incentive to participate, and 3 could not find a time to be interviewed within the time period allotted. So we were left with 22 patients who were interviewed between August and September of last year. Informed consent was taken by all participants. This was a study that was approved by the Yale Human Investigations Committee. The interviews were conducted in conversational Arabic in the local dialect, and they were done on WhatsApp. They were recorded, transcribed, coded for themes. NVivo software was used, and they looked at a framework analysis method with a feminist lens. Here are the demographics of the participants. So the mean age was 45 with a range of 24 to 67. Roughly half, a little less than half, 41%, were internally displaced. You can see that there were no patients in this study where stage was known who had early stage disease. All of these patients had either stage 2, 3, or 4 disease, the majority of whom, over 50%, were stage 2 and 3. 18% were not educated. Only 14% had a university education. The majority of these women had children and were married. And the majority of them were working as a housewife or were retired. So that gives you a sense of the population who were interviewed. And as these interviews were conducted, there were a number of themes that emerged. One was really this whole idea of the challenges in terms of accessing oncology care. And many of the participants were very grateful to SAMS for having established oncology care in Northwest Syria. They mentioned things like the fact that there was a center there actually reduced some of the challenges, including costs of transport and services in Turkey, being away from family and feeling isolated because of the linguistic barrier in Turkey, delays in permissions to cross the border, and restrictions on companions. Remember that many of these patients, if they couldn't get care in Syria, Turkey would be their alternative. But that was not all roses. There were transportation issues within Syria too that were problematic. Another issue that came up was really the financial strain, and I wanted to highlight some of the quotes that we got from participants who were interviewed. So participant number 8, for example, said, "We struggled a lot because my husband doesn't have a regular income. One day he works and another he doesn't. We are staying in tents. And now, because of the chemotherapy, I feel too hot in the tent. However, I try not to complain. The living conditions are very difficult. No one helps us with the cost of treatment. We had a freezer and a refrigerator, but we sold them so that I can continue my treatment." And that gives you a sense of what life is like for many of these people living in Syria in this conflict area, and the struggles that they face in terms of day-to-day living, as well as in affording the cost of treatment. There were also delays in care. One of the things that I should point out here is that radiation therapy is not available in Northwest Syria, and it's not available at the SAMS Oncology Center in Northwest Syria either. So for people who need radiation therapy, the only option is to go to Turkey. So participant number 1, for example, said, There is only one doctor to see almost 200 patients a day at the hospital that I was referred to. She's talking here about the hospital that she was referred to in Turkey. She goes on to say, one time I stayed 2 months in Turkey until my turn arrived. And by that time, the doctor said, you will need another radiotherapy treatment. And this was a recurring theme, this idea of delays in care being problematic for these patients. Another theme that came out that was interesting was in human relationships. A couple of the participants noted the real positive aspects of their family relationships that came out during their cancer journey. So participant number 13, for example, said, my husband did the impossible and he left the family and went with me to Turkey. He never left me alone. The amount of support I got from him made me feel that there is someone who really believes that I can recover and survive. This had an important role. Participant number 17 had a similar experience. She says, my parents-in-law supported me, and my husband in particular helped me in Turkey as my parents are not around. He was the first one to support me, thank God. The emotional and psychological part of this disease is important. As long as you have someone next to you supporting you, you will forget about the disease. And he was there next to me all the time. And so we can see that for some patients, they had incredibly strong family support, which really helped them to get through the breast cancer journey. But it wasn't all good. So participant 18, for example, said, cancer wasn't as shocking for me as when my husband left me. You feel you are not useful for anything anymore. This is harder than the disease, cancer itself. And she wasn't the only one. So participant number 4 said, I have 3 children. In the beginning, my sister took care of my son, who was 7 months old, and the other children were taken care of by my parents. Then the community started saying, my husband needs to marry again and have another wife to take care of the children. He did this and took the children, so they are far away from me now. And so you can see that it's not just the cancer journey that many of these patients had to deal with. It was also some of the human relationships, the cultural relationships, the family relationships that they also had to contend with. So that gave us a little bit of a taste of what the experience of these patients were as they went through the cancer journey in Syria. The second part of the study was really quantitative, trying to get at what is the presentation clinically of these patients? How does that compare to what we see here in the US? And what factors really impact stage at diagnosis, etc. So in order to answer the quantitative part of this project, we reviewed charts of women who were diagnosed with breast cancer at the SAMS Oncology Center in Idlib between 2018 and 2021. So we looked at 192 patients. The median age at diagnosis was 46, with a range between 22 and 80. So just to put that into context, right? If you think about the age at diagnosis of breast cancer here in the US, these are data that I'm showing you from the American Cancer Society, you can see that the median age at diagnosis here is 62. So a lot younger in terms of date at diagnosis for patients in Syria. Clinically, 16% of these patients presented with clinical distant metastatic disease. 70% had palpable lymph nodes at the time of their presentation, and at the time of surgery, 76% were found to have pathologically involved lymph nodes, and the median number of lymph nodes that were found to be positive was 4. The invasive tumor size was median was 4 centimeters, the range from 0.5 to 18 centimeters. So for those of you who may not be as familiar with breast cancer and its stage in the US, just to put this into context, and here again, I'm showing you data from the ACS. You can see here in the light pink bars across different races, distant metastatic disease ranging anywhere between 5 and 8%. And you can see that in Syria, the rate of having distant metastatic disease was roughly double that. And so we know that that is certainly significant. Prognosis of patients who have distant metastatic disease is far inferior. And in fact, when people have distant metastatic disease, although the disease may be treatable, it is not curable. You can see in the medium pink bars, anywhere between 24 and 31% of patients in the US will present with what's called regional disease, so lymph node positive disease. In Syria, again, more than twice that at 76%. And even when we have patients here in the US who have node positive disease, oftentimes that node positivity is only 1 or 2 lymph nodes. Whereas in Syria, the median number of lymph nodes involved was 4. In the US, many patients are presenting with even pre-invasive cancers, DCIS, or stage 1. Remember back to the qualitative portion of this study where none of those patients had that early stage disease. That's also reflected in this quantitative analysis where the median size was 4 centimeters. So we're thinking more into that stage 2 to 3 breast cancer. In terms of histology, so of the 192 charts that we reviewed where we had information about histology, only 3 patients, 1.6%, presented with DCIS. DCIS is pre-invasive cancer, essentially curable. In the US, that number is about 17%. In Syria, of the invasive breast cancers, roughly 81% were invasive ductal, 13% were invasive lobular. Those are similar to what we see here in the US. They had about 12% who were triple negative, that is to say that their tumors did not express ER, PR, or HER2 receptors on their surface. The number in the US is roughly similar, slightly lower at 10%. When we looked at how these patients were diagnosed and treated, you can see that 92% had the diagnosis made based on excision. There's been now an international consensus that ideally we want to diagnose these patients using minimally invasive techniques like needle biopsies, usually a core needle biopsy. And in Syria, only 4% of the patients were diagnosed based on core needle biopsy. Now, our analysis did not get into why that was. I can tell you based on experiences that we've had in other areas of the world. For example, my brother does a lot of work in global health in Tajikistan, where core needle biopsies, the actual device itself, are just very hard to find. There's simply a lack of supplies. And so that may have played a role here, but again, we don't have information on that. Despite these cancers being fairly large and locally advanced at presentation, where we here in the West would have treated those patients with chemotherapy first, many of those patients went on to receive surgery as their initial treatment, 94% of them. And again, further work needs to occur to really dig into why that was. It may have been the fact that chemotherapy may not have been available. It may have been due to anxiety on the part of patients, or the fact that they were facing, fungating breast lesions where what we would call here in the West a toilet mastectomy or a palliative mastectomy was required simply to control the local disease. Again, we do not have information on the rationale behind these figures, but rather this is more hypothesis generating rather than definitive. What we do know is that they had a very respectable time between diagnosis and surgery. A median of 15 days is certainly acceptable even here in the West, but you can see that that range was from 0, perhaps by people who had an excision of their cancer, which was also curative at the same time, all the way up to 756 days. So that is more than 2 years, which certainly is problematic. We then looked at a number of other interesting questions that we were able to parse out from the data that we collected. One was exposure to chemical weapons. Now, in the analysis, in the data that we had gathered, only 7 patients had exposure to chemical weapons. And so that's something certainly to keep in mind. These are small numbers. And so, as you can see, we did not achieve statistical significance on the basis of any of these clinical pathologic factors, but it may well have been related to the fact that we were comparing to such a small sample size. But if you look at the actual numbers themselves, you can see that those who did have exposure to chemical weapons, albeit that these are not statistically significant, tended to be higher grade, more often triple negative, more often to have clinical distant metastases, more often to be node positive, more often to be larger in size. Which raises the question, if we expanded this study, wouldn't we in fact reach statistical significance? Again, hypothesis generating rather than definitive. The next question that we looked at was seeing the difference between citizens or host populations and those who were internally displaced. So here you can see that in the cohort of charts that we looked at, over half of these patients were in fact displaced. This goes back to the fact that in the Northwest Syria, that is roughly the percentage of the population who are displaced. And you can see here that we found no statistically significant difference in terms of any of these clinical pathologic factors, which goes to say that people are people. Whether you were displaced or not displaced, the type of breast cancer that we saw amongst these two populations were very similar. And you can look at the individual parameters here and you can see that they're very similar. One of the things that was interesting, however, when we looked at the differences between the host population and the internally displaced people, was that there was a trend, albeit not a statistically significant trend, but still a trend with a p-value of 0.051 towards a shorter time from diagnosis to the initiation of treatment for internally displaced people. Now, on the face of it, that may seem counterintuitive. You would think that those who are internally displaced would have a harder time accessing care. They should have a longer time to treatment. But I think that there are a few things to keep in mind here. One is that, again, remember, this may not truly be a shorter time interval. We did not hit statistical significance. It's only a trend, and it is still a relatively small sample size. However, the other thing that I think that is important to keep in mind is that these patients had already accessed care. They had already been diagnosed with breast cancer at the SAMS facility. And so the ray of light here might be that those people who were diagnosed at the SAMS facility in northwestern Syria, it didn't seem to really impede those who were internally displaced in terms of getting their treatment. If anything, their treatment was slightly shorter 14 days versus 19 days from the time of diagnosis than the host population. And this may have been related to other issues, right? The host population might have included citizens who were employed, who might have had other obligations where it may have delayed them somewhat in terms of getting their treatment. And clinically, the difference between 19 days and 14 days is not terribly dramatic. So I think it's at least reassuring that internally displaced people, once the diagnosis is made, could get treatment in a relatively expeditious fashion. So in summary, there are a number of unique challenges faced by breast cancer survivors in northwestern Syria in terms of access to care, transportation, financial strain, family tensions. And when we look at breast cancer in Syria, at least in the northwestern part of Syria, in the SAMS oncology centers there, the presentation tends to be younger women at a higher stage, more often triple negative, more often diagnosed with excision than what we would see here in the US. Again, this study only scratches the surface. I think that there is still plenty of work to be done. If we compare those who were exposed to chemical weapons versus not, there were no statistically significant differences in terms of clinical pathologic factors. But there again, I wonder whether that is just related to the small sample size, because when we look at the actual numbers, we do see differences that may be meaningful. But citizens or host populations and those who were internally displaced had very similar clinical pathologic characteristics. And at least for those who were treated in the SAMS facility in Idlib, there was no difference in the time to treatment between those populations. And if anything, there was a trend to the internally displaced populations getting a slightly shorter time interval between diagnosis and treatment. So this study would not have been possible without a wealth of collaborators. Kaveh mentioned how this study got started. Jude Alawa, who Kaveh mentioned, should be on this slide, so my apologies for that omission. You can see here our SAMS colleagues, as well as a number of students at Yale who participated in making this work possible. So I'm going to stop there, and I am happy to answer any questions that you might have.
Hi, I just have a general question. So you mentioned about the difference between no difference between cancer treatment for the people who are internally displaced and the host community. I don't know if with these SAMs, do they collect also information for other diseases? Is that like something that you see as well?
Yeah, so our project only focused on breast cancer patients. So the charts that we reviewed were all breast cancer patients. I do know that the SAMS facility there does treat other kinds of cancers, and may, although I'm not sure, and Kaveh, you might know better than me, may also treat other diseases as well. I know that they do treat other cancers, but we did not look at that. That might be something for future study as well.
Maybe I can ask a question till others are processing, I'm sure. Thank you so much for that presentation. And it's really, to my knowledge, Syrian American Medical Society is one of the few international humanitarian organizations that actually offers cancer care and treatment. I think there's a lot of humanitarian organizations that, for a variety of reasons, don't see cancer care and treatment as part of their responsibilities. I think Doctors Without Borders, MSF, does that. So of course, I'm interested in figuring out how do we make this case to other humanitarian organizations that cancer care and treatment is not something that should be neglected, because the population you're talking about, they're stuck for decades. So they don't just have sort of acute, let's say, infectious disease issues. They have chronic conditions. Cancer, of course, is one of them, but I'm sure there's diabetes, there's hypertension, there's all kinds of NCDs. But in general, humanitarian organizations don't seem to focus as much on NCDs as they ought to. So I don't know if you have any thoughts about that. How do we make that case that NCDs should become a priority for humanitarian organization? And the other question I had was on breast cancer prevention. I'm just wondering if there's any strategies that can be done in reducing breast cancer in displaced populations in humanitarian settings.
Yeah, so two very important questions. You know, the first one is really difficult, right? Because we know, particularly for cancer, it's an expensive disease to treat. And it is an expensive disease to treat because it requires a multidisciplinary effort. It requires a lot of infrastructure. It requires specialists. And so for humanitarian organizations who are trying to deliver care, one can imagine that, you know, when they look at their limited resources, that they say to themselves, where's the best place to spend our buck? And, you know, kind of get the biggest wins that we can in the shortest period of time that we can for the least amount of money as we can. And so I think that therefore takes people into the route of, well, let's make sure that there's clean water. Let's make sure that there's sanitation. Let's make sure that, you know, we can feed children. Let's make sure that we can treat infectious diseases. And those things are important. But to your point, you know, as we see these conflicts that are not limited in time, that are extensive, we know that the mortality associated with non-communicable diseases is going to far overtake the mortality associated with communicable diseases. But I think that the case is difficult to make to these humanitarian organizations because it is a big lift, right? It is a lot of money to expend, and particularly for things like cancer, which is so complex. You cannot think about breast cancer being the same as prostate cancer or lung cancer or colon cancer or leukemia. And so now you're treating many different diseases. It becomes difficult to have the expertise, the infrastructure, etc. Whereas other non-communicable diseases, heart disease, hypertension, diabetes, might be easier. And I think the last point that I'll make is that the impact that you see, many of these humanitarian organizations, they want to see impact because that's their lifeblood, right? They are relying on funders. They are relying on people, philanthropic donations, and to fund their mission. And part of the way that they harness that is to say, look at the impact that we're having. And cancer is one of these where, you know, impact is measured not in days, but in years. And it can take a long time to see your impact. And so I think those are the issues that these humanitarian organizations face. I think one of the ways to get over that is to do a better job in terms of taking care of the immediate issues, so that once those immediate issues are done, then these humanitarian organizations can kind of say, well, what else is there to do? And then work at the next issue, which will be the non-communicable diseases. Now, this is not to say that I don't think that they should do work in cancer. This is my lifeblood, but I understand. I understand the difficulty that these NGOs face. In terms of prevention, this is another one that's hard, right? Because if we think about primary prevention, which is really what I think you're getting after, how do you prevent the disease from the first place? It's really hard. If we think about primary prevention of breast cancer, reducing risk factors, well, what are the two main risk factors for developing breast cancer? Being born female at birth and getting older. Like, what are you going to do? Family history plays in. If we can avoid nuclear disasters, radiation plays into breast cancer. So if we can have world peace, that might help. But the modifiable risk factors are few, right? And they're the ones that everybody knows about, right? So if you can reduce obesity, increase physical activity, maintain ideal body weight, we know that you will reduce your risk of many cancers. And P.S., you will also reduce your risk of many NCDs that are also key killers, right? Heart disease, diabetes, stroke, et cetera, et cetera. But we also know that, our world population is getting more and more obese. So if we could do something on that front, that potentially is a very cost-effective way of having a meaningful impact. Will it have an impact that will be measurable in days? No, but it may have an impact that will be measurable in years. Other things, alcohol. Well, okay, but particularly in the Middle East with a large Muslim population, that may not be as much of an issue as it might be in Western countries. Exogenous hormones, taking hormone replacement therapy. Again, something that in developing countries may not be as prevalent as it is here in the West. And even here in the West, we've seen that after the Women's Health Initiative study came out demonstrating that exogenous hormones increase the risk of breast cancer, we saw that rate decline and similarly saw a decline in breast cancer incidence. But if we think about as a whole, breast cancer is one of those where, there aren't a lot of things we can do in terms of primary prevention. The other thing is, on the family history side and the genetics, we've done studies, for example, in Trinidad and Tobago, in Pakistan, where we found a high prevalence of triple negative breast cancers in younger populations, trying to see whether they had a higher rate of genetic mutations. If they have a genetic mutation, it doesn't mean that we now magically can resolve this, but women can do things that will prophylactically reduce their risk, right? So you can do prophylactic mastectomies, which will reduce your risk by 95%. However, then you come into the other problem, which is in many of these areas in the Middle East, in Asia, there are cultural stigmata that play into this, right? And so even patients who face a diagnosis of breast cancer, many of them will say, I was really scared to have treatment because if I lost my breast, then I would not have been marriageable. And if I was not marriageable, then I would have been excluded from the community, right? And so the aspect of, well, if we only knew the genetics of the population, we could take steps to prophylactically reduce risk, also has problems, right? So this is one of the things that I always find challenging about global health, is that for everything that you think of as a potential solution, there are 9 other problems that emerge. It's kind of like this onion that you keep peeling the layers of the onion and there's still more layers underneath. So Kaveh, you've had more experience than me in this whole area. What are your thoughts?
Well, I developed my humanitarian research lab because I want the research to be beneficial to humanitarian organizations and policymakers. And I think that to me is a critical thing. I'm so glad that you've done this research, and I'm really hopeful that SAMS is able to use these evidence and to apply for additional funds, to get more support, because now they have some data to share. So that's really I feel like just bringing some attention to this and doing research that humanitarian organizations may not have the time or the capacity to do that. That's our role as an academic institution.
Yeah.
And can I ask as well, because these are areas that are clearly have been affected vastly by the conflict. So how hard is for these institutions that are able to give the support to continue doing that? Because obviously it's very different if you are in a peaceful setting, and then to be able to plan ahead rather than just trying to survive. And when you were saying about, I mean, all of the diseases that they look at, I mean, you would imagine that probably trauma would be one of the very first one that they have to, or they take care of, both physically and hopefully mentally as well.
Yeah. No, I think that SAMS, has been blessed to have a reasonable philanthropic arm that helps to fund some of its work, and they are very committed to really improving particularly cancer care in northwestern Syria. But to your point, I think that we saw that even SAM's facilities had been embroiled in this in the conflict, right? We know that the conflict had targeted healthcare facilities, and so it's really tragic when you're trying to help populations and you're finding yourself on the receiving end of the conflict that you're trying to help.
And to the part of the cost, they're able to provide all of these services without any
yeah, so they offer their services free of charge, but again, I think that they are very reliant on donors and on fundraising, and on grants, and but so far, my understanding is that they do offer all of this care free of charge. Angie, I see your hand.
Hi, this is just terrific. Thank you so much for sharing and for doing such important work. I have a question more around methods, and I love how you have triangulated. You've looked at the epidemiology of it. You have thought of the possibilities of the molecular genetics of it, but you've also done some of the qualitative work around it. So I love the way that you are truly approaching this from a mixed methods approach. Can you talk a little bit about what the qualitative process looked like? Was this mostly like looking for emergent themes in the experiences of women, or did you come in with a priori, maybe ideas or assumptions of what was highly relevant to them? And then the second part to that question is, what does your sort of the Syrian academic engagement look like? What potential, what role do you see there in kind of complex, public health questions like this one? Thank you.
So full disclosure, I was not directly participating in the qualitative portion. This was really done by our colleagues through SAMS. My Arabic is much worse than their English, because my Arabic is pretty much non-existent. But my understanding is that the interviews were conducted without any necessarily a priori understanding of themes that would emerge, but really those are themes that came out of the conversations as they occurred, and the researchers who had much more of an experience in qualitative research than I did kind of applied this framework methods to the interviews that they got, used in vivo to help code for themes, had consultation between investigators to really parse out what were the themes that were emerging, and kind of went from there. In terms of the second question of academic partnerships, I think that this is still emerging. So this was the first project that I had done with SAMS. They have researchers both located within Syria at the university there, as well as in the UK and in the US. And so we were able to kind of partner together in a transnational way to answer questions that were important to all parties. Kaveh, I don't know if you want to add anything.
I think you covered what I was thinking about. I was also thinking about how I know you were particularly interested in trying to hire Syrian medical students in Northwest Syria to participate in this. And there was a lot of policy issues around being able to fund students in Syria. And so that was a bit challenging, but we somehow still managed. It took a couple of months to figure out how to do the qualitative work, but yeah.
Yeah. To that point, Angie, I think that Kaveh brings up a good point is, there are regulations between, what can pass between the US and Syria because of embargoes and so on and so forth. And we complied with that, right? Like there are rules that, you have to color within the lines, but hopefully, you can still collaborate and find interesting ways that you can partner to answer important questions.
Wonderful. Thank you. Thank you so much.
Thank you, everybody, for joining us, especially Angie Ponguta. I'm so glad to see you. Angie has done some wonderful work on early child development in Lebanon and in many other countries. So thanks for joining us. Dr. Chagpar, thank you so much. This was incredible, and I really hope that this research will make a difference for the Syrian population who are struggling with cancer and many other issues. So thank you.
All right. Thanks, everyone. Take care. Have a great day.
Bye-bye.
Thank you very much for the presentation. Excellent.
Thank you, Teresa. Bye-bye.